Welcome to the Dr. Doug Show, where I combine two critical components of self-mastery, HealthSpan, and mindset. The topics presented here will help you to improve both your body and your mind, and to help you to live better, longer.
3, 2, 1.
Here we go!
So what if I told you that there was a simple screening that could make the difference between life and death? Intrigued? Well, stick around because we're going to talk about preventing one of the most common cancers in the world. We'll discuss traditional screening methods as well as new technology that is really promising. I'm going to share with you why I make the recommendations I do for my patients. But I also recently went through my own experience of screening for colon cancer with colonoscopy, and I wanted to share some of my takeaways to help maybe ease some of the fear and concerns that maybe you have around this form of screening and prevention. Keep in mind that if our goal is to improve our health span and to live better, longer, some of the easiest ways to do that are not to die of some of the most common causes of death. So, all right, why colon cancer? Well, the thing is that it's more common than you think. According to the American Cancer Society, colon cancer is the third leading cause of cancer-related deaths in the United States. And cancer is the second leading cause of death in the US for adults, behind heart disease. So here's the kicker. Colon cancer is one of the most preventable forms of cancer. So let's talk numbers. In 2022, it was estimated that over 52,000 people would die from colorectal cancer in the US alone. That's a lot of people. But it doesn't have to be that way. And you might be thinking, hey, look, I'm young. This doesn't apply to me. But think again. While it's true the risk increases as we age, the rates of colon cancer in people under 50 have been rising. So age is really no longer a safety net. And as of 2022, 12% of colon cancers are diagnosed in those under the age of 50. And while that might not seem like a lot, not a lot, when you consider that 12% of over 106,000 cases occur in the under age 50 group, it's actually a pretty big number. Now, arguably, the majority of these are asymptomatic, and that makes screening all that much more important. But you might be wondering why it's so important to screen for something that doesn't cause any symptoms. So think of it this way, if you're not familiar with cancer treatment. If colon cancer is caught at stage 1, meaning the very early stages, the 5-year survival rate, meaning those that are still alive after 5 years, is about 90%. But if it's diagnosed at stage 4, that number drops to about 14%. That's a big freaking difference. Not to mention that in early cancer, you could be treated with a much less invasive, or at least a smaller scale surgery to cure the problem. Also, treatment at earlier stages, cancer may not require some of the same additional chemotherapy or radiation that may be required at more extensive stages and higher stages. So every cancer is different, but in general, earlier is better. So the way I counsel my patients is that we want to screen for colon cancer in really one of 4 ways. There's some really cool new technology to consider, and I want to review some of that briefly. I want to demonstrate, though, that they are not necessarily alternatives to traditional colonoscopy, and I want to go through some of these things in some detail. We're not going to get into all of the weeds of these things because I'll do a full podcast on some of these things, but I want to go through them because I see this, especially with colonoscopy, because ultimately, it is a procedure. Colonoscopy is a kind of an undertaking, and I'm going to, again, walk you through my experience. But I want to walk you through this thing called liquid biopsy. So one of the newest cancer screening technologies that's out there is called a liquid biopsy. The test that we use is a test called GALLERI from the company Grail. I'm actually going to pull up for those that are watching this. This is for the physician kind of education piece of this thing. But essentially what this is it's a blood test that will detect a methylation pattern or DNA of cancer that is surprisingly free-floating in your blood. The problem with this and any test is that it's not perfect. So it doesn't catch every cancer. And the only thing probably worse in the cancer field than a diagnosis of cancer is actually a false positive diagnosis of cancer. So you really want to be careful when you start using screening methods, especially newer ones that don't have as much evidence behind them or history behind them, because we don't want to do harm, right? There's a whole thing about that. So we do want to use these things in an educated way. We want to do them at the right time for the right patients. And so if you look at this, what I pulled up on the screen here for those that are watching this, and I'll walk you through it for those that aren't. This is a graph. This is from the GRAIL company itself, but this is from a very large study they did looking at the sensitivity and specificity, and I'll explain those, but the sensitivity and specificity of this test for individual cancers. And so if you look at this graph, you can see that it starts low on the left and it climbs on the right. And these are all different cancers. So for those that can't see this, these are different cancers, and it starts with kind of some unfortunately common cancers like thyroid, and breast is on the low end of sensitivity. And then it goes out to some of the more like bloodborne cancers, which are obviously going to be easier to recognize in blood, and those are on the far end. And on the vertical axis, we have the actual sensitivity, and the sensitivity means the likelihood of catching or identifying a positive if you have the disease of interest. So something that is 100% sensitive means that the test would identify 100% of the cases if you were to do the test on somebody that had it, and vice versa. If it's 0%, then it would miss all of them. There's a lot of nuance to the discussion of statistics around here, and there are so many things we could discuss, which we'll do again in another podcast. But for the sake of this podcast, just know that colon cancer is somewhere in the kind of upper end of this. So it says colorectal cancer, and it's a little over 75% sensitivity, which means that if you have colon cancer, it'll find it about 3/4 of the time. Now, that, depending on your history of statistics, might actually sound good or bad. I would love for it to be much higher, but at the same time, we also don't want it to be too high, because generally something that has a very high sensitivity is also going to find a lot of false positives or identify a lot of positives unnecessarily. So this is kind of a challenge. And we're going to talk about this in comparison to colonoscopy in a little bit, but that's where this GRAIL test or the blood test is kind of sits. Now, the next thing that people often will talk about is a full body MRI. So full body MRI is a popular modality for cancer screening. It is something I think that is, it's gaining momentum. Neither GRAIL or a full body MRI are covered by insurance, but there are a lot of companies out there that are offering these things. The challenge with a full body MRI is that I don't think that there is enough data to support using it certainly as your only tool. Maybe an additional tool. The challenge I see too is that people will think that if they get a full body MRI, they don't need to do, say, a specific body part MRI. So like, for example, if a woman is very high risk for breast cancer and has a specific type of breast tissue, she might be recommended to get an MRI over an ultrasound and certainly over a mammogram. But the full body MRI is not a substitute for that breast MRI. Same thing for men with prostate cancer. A full body MRI is not going to give you the same anatomic detail as a prostate MRI. And so we have to be careful with the recommendations here. But as a screening tool, there is some evidence to support relatively high sensitivity and specificity with the MRI overall. The challenge with these studies, and I have one pulled up on the screen here from 2015, which is not by this company, but uses similar technology. When you read through these studies, it's kind of what's happening is that you're looking at what is the sensitivity of people with known cancers. And so this is a little bit of a different question than if we're using this as a screening tool in people that don't have cancer. And also what I can't find in the literature, and again, we'll do a deep dive on this, but what I couldn't find in the literature out of the gate was at what stage are the cancers that are being identified on MRI? At what stage are they being identified? Knowing that the GRAIL test, in theory, can identify very early cancers because it doesn't take much cancer mass, cell mass, to create DNA that's going to be found in the blood. Similarly, we'll talk about colonoscopy in a minute, but similarly, there's some other tests which we'll talk about that look for DNA as well. But if you're looking at it on a full body MRI, you need a pretty significant sized mass, and that's likely already going to be past stage 1. Maybe not in the colon, but it's going to have to be pretty big to be able to be picked up on a full body MRI. So there's a little bit of a challenge there. So then the fourth, I mentioned there's 4. The third of the 4 is what's called Cologuard. So Cologuard, which is a brand name of this type of test, but this is a stool test looking for, again, DNA. So because the colon is a very specific part of your body where you have an output, hopefully daily, you can actually look in that output, which is your stool, and see if there is DNA from cancer in it. So there are tests that can do this. The specificity for cancer, colorectal cancer, is about 80 to 90%. And let me just clarify that for a second. Specificity is not the same thing as sensitivity. Sensitivity is finding it if you have it. Specificity is not finding it if you don't. So it's a different way to ask, kind of the same questions. But the goal here is that you don't, again, want false positives. You want to identify it if it's there. But the truth is that it's not as sensitive or as specific as colonoscopy, which we'll talk about next. So what I want to impart here is that while this is a potential test for people that are unwilling or unable to go through colonoscopy, it is really not a substitute for colonoscopy if you haven't had a colonoscopy. So that brings us to colonoscopy. So why do people do colonoscopy? It seems barbaric. I think about this, I'm thinking, man, like it's kind of a crazy thing to do, to completely evacuate the colon, to stick a scope up the colon, risk damage of perforation or other issues by doing the procedures so that you can visually look at the tissues. It seems a little crazy, even for someone who is a surgeon who used to really, get a lot of information by directly visualizing structures. It just seems like this can't be good for the body. But the thing is, the advantage is that direct visualization provides you with so much information. And also, when you do see something, you can potentially biopsy whatever you see. So if you have what would be called a polyp, and polyps can be a lot of different things, but if you have a polyp, which is potentially could be the early stages of cancer, or if you actually see something concerning for cancer, you can actually biopsy it and you can send it to the lab and you will know right away. Whereas if you get an MRI and you see a lesion, then you have to go back and do the thing. And so it is really helpful in not only prevention, but also a prognosis if you actually have something. And it is the gold standard. So while there is no perfect test, there is no better test. And that's really, that's really the challenge around some of the other things, is that you're really comparing it to something that is really difficult to improve upon, because you can see it, you can biopsy it. The question is what about the risk? So I turned 45 this year in 2023, and the recommendations are to get your first colonoscopy at the age of 45, potentially earlier if you if you're a high risk for colon cancer. And so, as an educator in longevity and cancer prevention, I felt I was obligated to do this, not only for myself but for my patients. And so, also as a self-experimenter, I wanted to go through this so that I could educate people on what it's like. So going into it, I had very little trepidation. I don't do a lot in the traditional medicine space, but I wasn't concerned about the risk. As a proceduralist, a surgeon, I know that if you are in good hands, then really the risk is extremely low. Also, I don't have any reason for it to be any higher risk. Now, that said, what was a little unnerving as I started going into it is that with the practice that I went through, it was amazing. It was an amazing reminder of what it's like to be in the traditional medical system. We sent in a referral, and I never talked to anybody. Nobody knew who I was. It was all app driven. And it was amazing kind of amazing that I was able to actually get to the process of showing up the day of the procedure and never having talked to anybody. But talk about feeling like a number. Wow. So through the app process, you get a recommendation for what kind of prep to do. Again, no discussion. I sent in some paperwork, so I don't know what happens on the back end, but they didn't know me. They didn't know anything about my bowel history, how regular my bowel movements are, or anything like that. You just get sort of this like blanket recommendation, right? And so for me, 4 days before, I was recommended to take a drug called Miralax, which is an osmotic laxative, which will help you to have bowel movements. And it's actually, for people that have constipation, our favorite choice of laxative. But I did that for 4 days. And then the day before, you start what is called the quote unquote prep. The prep, for anybody that hasn't done this, is, what's the best way to describe it? It is somewhat challenging. the liquid that you drink about a half a gallon initially, and it tastes pretty terrible. You are also recommended to consume a clear liquid diet. And I think for a lot of people, a clear liquid diet for 24 hours in the presence of doing this sort of dehydrating thing is pretty rough. As somebody who is used to fasting, that wasn't an issue. That part was fine. But then, basically dehydrating yourself and needing to take water on top of, basically passing a bunch of water is pretty darn uncomfortable. I certainly would recommend staying at home. You should not leave the house. I did actually run an errand, and I got really nervous because as I was driving around thinking, boy, I should probably be closer to the house than I am right now. So fortunately that worked out. So the prep starts the evening before, and they recommend to start at like 5, and then you drink all this stuff, and then you pretty much evacuate everything in your colon. And then you can sleep for about 6 hours, and then you do it again in the morning. And it was something I learned is my procedure was at 9:30. You're supposed to start 5 hours before your procedure, or 6 hours, somewhere in there, which is, 4 in the morning. And so if I were to, when I do this again, I should say it that way. I'll choose a slightly later start time so that I don't have to start this at 4 in the morning. But the day of the procedure, you do it again. Then you hopefully can slow down the effects of the prep, and then you drive to your procedure center. You get you get checked in, and it is like in the ballet world we call it a cattle call, where it's just so many people getting procedures done, and it's a remarkable demonstration of efficiency. I'll also say too that even with our insurance, which is my insurance is mostly catastrophic, it's not amazing. It costs nothing because it's a covered procedure. So I'm very used to surgery centers. And so when I showed up, I expected to, I would meet people like as we go. So showed up, got checked in. I met the doctor. He was very nice, very experienced, but I hadn't met him before. He spent about 30 seconds asking me questions. And, as he's doing so, kind of like poking around and doing the required physical exam, which I don't think really demonstrated much for him. And then we got to the point where, and this happens when I had shoulder surgery this year, whenever people start asking me, oh, what do you do? And I have this sort of like very short version, depending on how much I want to get into the conversation. And so inevitably with physicians and with other medical practitioners, they get really interested. And so it turns out that before we go through this procedure, the doctor tells me that, that he's exhausted and he does 14 of these a day. The CRNA is retiring. The nurses are overworked. Everybody's kind of struggling to keep up, because in the traditional system, it is such a numbers game, because reimbursement is so low that in order for them to stay profitable as a center, they need to really, really push people through. And then interestingly, they asked, hey, do you want to watch? Do you want to, how much anesthesia do you want? And so I appreciated the comment, and I did want to minimize anesthesia. And this is something that, as somebody interested in longevity, you really, I should impart to you that you want to minimize anesthesia. So the goal of that procedure was to use propofol, which is a narcotic, but it's pretty short acting. And so kind of quick on, quick off. So I said, hey, you know what? I don't know that I'm going to tolerate the procedure, so let's just use a little bit, and then let me wake up and let's see how it goes. And so what we did is that we went light with the anesthesia. I fell asleep before the procedure started, but I woke up about halfway through. And what I found is that it really wasn't particularly uncomfortable. I was able to talk to the surgeon. We had a nice discussion of what the findings were. I had one tiny little, very benign appearing polyp that they biopsied, which was nothing. And that was it. But I was able to kind of walk through the procedure with him, and we were able to look at all the different areas, and I got to see the inside of my colon. But the reason why I share that is that it's not an uncomfortable procedure from the get-go. I probably would have been fine without any anesthesia. And talking with my older patients, they didn't used to use any anesthesia for this. So I wouldn't be worried about it from that perspective. So again, colonoscopy or any kind of colon cancer screening is something that everybody should consider as we age. Again, if we want to live well for as long as we can, we need to avoid dying of the things that are most likely to kill us. And cancer is number 2 for everybody, all adults in the United States. So If you are 45 years old or older, then you should have your first colonoscopy. This is recommendations from the American Cancer Society, as well as the USPSTF, which is the United States Preventative Services Task Force. I said that wrong. That's okay. So 45 years or older, and if you have a family history or at higher risk, then potentially sooner. I recommend for my patients to do a colonoscopy. Do not substitute with a Cologuard, and do not just use a full body MRI or a study like the liquid biopsy, the GALLERI, the GRAIL. You can do those in addition, but don't do those instead, if that makes sense. All right. And so with that said, thank you for watching. And if you haven't already joined our HealthSpan network, I strongly encourage you to check that out. Go over to drdouglucas.com. You can join us there, which is where we provide all of our resources, discount codes, weekly Q&A with myself and team members. And we will probably likely start having some interviews through that platform as well. So if you're interested in living your best life, I strongly recommend joining us at the HealthSpan network. Otherwise, I will see you next time. Disclaimer. This presentation is for general informational purposes only, does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to this presentation are at the user's own risk. The content in this presentation is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay obtaining medical advice for any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. See you next time.